Hello, my name is Jean Elliott. I am a Maryville University DNP candidate and I plan to graduate on May 8, 2018. My research work regards violence reduction in the inpatient setting using a mindful presence intervention. Mental health care workers, including registered nurses, may enter the inpatient psychiatric setting unprepared to care for patients with severe mental illnesses commonly associated with aggression and violence. Necessary psychopharmacological treatment is frequently refused by these patients, possibly making the psychiatric nurse at the highest risk of violent assault of all the nurse specialties. Aggression de-escalation strategies are necessary. The mindful presence intervention, a de-escalation strategy, was developed by combining the three significantly successful strategies of mindfulness, peaceful presence, and giving adequate safe space to allow the patient's expression of anger. The formal research question queries how a mindful presence intervention may reduce aggression and violence in an inpatient psychiatric setting. The purpose of this scholarly project is to decrease the rate of assault on mental health care workers who care for severely mentally ill patients. This translational research addresses the incidence of assault on workers by these patients to identify how the assaults may be reduced after implementing interventions based on peer-reviewed, evidence-based research into practice. Inpatient mental health care workers lead all other industry sectors in the incidence of non-fatal workplace assaults. The rate of non-fatal assault for non-healthcare worker sectors is 2 per 10,000, while the mental health care workers have 43.2 assaults per 1,000 workers. Workplace assaults are underreported, so the problem is larger than the reported statistics. Predicting when aggression transforms into a violent act is difficult. Liabilities associated with violence heightens awareness of the urgency to predict it. Mental health care workers have a legal obligation to protect patients. Yet, if they respond too early to what appears to be a dangerous aggression, these workers may be legally scrutinized. Psychiatric inpatient workers are challenged by the necessity to balance control and care. The worker strives to meet human needs in a moral manner, leading to the need for additional non-coercive interventions when confronted with aggression. Non-coercive strategies are associated with improved therapeutic relationship and medication adherence. Gene Watson's theory of care forms an applicable theoretical framework for my research. The psychiatric patient experiences the world differently than the majority of people, requiring the nurse to feel compassion and to have an awareness of personal and environmental energy patterns. Connecting at the compassionate level of human caring provides a bridge of awareness between two people who may not have much else in common. The project utilized a mixed research, largely quantitative with a small qualitative component, pre-test, post-test design. The qualitative focused on lived experience and finding meanings by the teasing out of themes. The setting was a forensic psychiatric inpatient residential facility with 30 beds, usually occupied by patients with severe mental illness. The samples were census. While all facility mental health care workers were taught the mindful presence intervention, the survey was administered only to the professional workers, and 19 participated from a population of 20 professional workers, establishing a survey statistical data accuracy with a 95% confidence level and a 5% error margin. The survey sample consisted of psychologists, registered nurses, counselors, and management at the project facility. For the incident report sample, only those incidents documenting a patient-to-worker assault were appropriate to the study and included. The project was approved by the Maryville University IRB and followed all the requirements. The data was collected from incident reports and a survey. 15 study-appropriate incident reports revealed the trends of the patient-to-worker assaults for 3 months before and after teaching the mindful presence intervention to the facility staff. Toward the end of the project, the survey revealed the professional workers' thoughts on the intervention. Data was quantified and categorized systematically. One open-ended question on the survey allowed for a small qualitative component to be examined. This triangulated approach allowed the data from the survey to complement the data from the incident reports, increasing understanding of the effectiveness of the mindful presence intervention and strengthening the validity and reliability of the scholarly study. The research procedures occurred over 6 months. A Z-score calculator was used to compare the assault rate for the two population proportions before and after teaching the mindful presence intervention to all the facility staff. Population 1, or all the dates and censuses in the pre-group proportion, contained 11 assaults, and Population 2 from the post-test group had 4 assaults. Using a significance level of 0.05 with a two-tailed hypothesis, the Z-score was 1.8383, and the p-value was 0.06576. The null was not rejected, though close. Clinical significance was demonstrated as during the 90-day pre-test period there were 11 assaults and only 4 assaults during the 90-day post-test period. And when considering similar overall patient census, the pre-test ratio was 0.013 while the post-test ratio was reduced at 0.005. This table indicates the 90-day pre- and post-test data. Also noted is 3 injuries pre-test and none post-test. The first survey question, was the intervention perceived able to reduce assault? And the graphed results indicating most believed the intervention was able to reduce assaults and none did not, indicating a genuine effect and adding clinical significance. And the second survey question, did the participant believe an assault may have been prevented using the intervention? The graphed results indicate most believed the intervention reduced assaults, while none did not, indicating a palpable effect and clinical significance. "14 participants added written thoughts to the survey. The additional comments on the survey reflected what the researcher heard expressed in team meetings and observed in the clinical setting. Rigor was added to this qualitative aspect by reviewing the themes teased from the material with a facility administrator. A summary of the qualitative data indicates the intervention was largely perceived as useful, adding clinical significance to the functionality of the mindful presence intervention. The individual elements of the mindful presence intervention are evidence-based and may be potentially relevant and researched in any setting where a patient is aggressive. While the two-tailed t-test of the incident reports in this mixed study does not reveal statistical significance, The mindful presence intervention reveals clinical significance in the supporting incident report ratio analysis and the professional mental health care worker survey. These mixed data results imply the mindful presence intervention needs more time and a larger sample to achieve statistical significance. The implications for nursing practice include the replacement of coercive strategies with non-coercive strategies, improving the ability to form a therapeutic relationship with the patient, and improving patient adherence to the necessary medications prescribed, thereby reducing decompensation to mental illness. Every study has its strengths and weaknesses. This study had many strengths, but needs more time to mature. The current levels of aggression and violence in the psychiatric settings are unacceptable, indicating need for interventions to reduce the assaults. De-escalation techniques, such as the mindful presence intervention, are an integral aspect of care occurring when an aggressive patient escalates toward violence. The project facility continues to use this mindful presence intervention successfully, reducing assaults, promoting worker retention, and increasing the quality of care for the facility patients. These are my references. I hope you enjoyed my presentation. You may contact me with any questions at the email address on this slide, noted below. Thank you so much for watching.